Perfect. So you can probably tell from my accent that I'm from the UK. And I'm actually from a place in the northwest of the UK. It's quite an industrial area, quite a working class area. And my parents invested a huge amount of time, made a lot of sacrifices to ensure that I had the best education possible. And what that meant was we moved around a lot, always to smaller and smaller houses, but to better and better schools. And the reason they did this was because they felt that education was the key to success, that there was nothing better that they could give me than a good education. And so when I got into Oxford, they were really proud, super proud. And when I graduated from Oxford Medical School, they really felt that was the culmination of all their efforts. And they really felt they could sit back and just watch me succeed. And sure enough, they were right for a while. I continued, I progressed, I trained as a surgeon, and I enjoyed my clinical career. But then they were really shocked to learn that I was going to quit clinical practice. And it really devastated them, and they really couldn't understand why I would throw all that away. And the reason I share this with you is because I don't think I'm throwing it away. I think the technology that we have at Pentavere is going to allow me to impact thousands of lives, whereas before as a surgeon, I was impacting tens or hundreds. And it's because as a surgeon, I was trying to practice evidence-based medicine. But that's really hard to do when you don't have the evidence to answer some of your simplest questions. We invest billions of dollars worldwide on drug development and drug discovery. And that's right, that's appropriate. But I just kept thinking, what about that real patient in front of me? What about the real world evidence that could tell me so much? You saw me walk up here with a prop. This is one patient's lung cancer notes. It's anonymized, I'm allowed to share it with you. It's 200 pages of dense, unstructured text. And we had a great talk earlier on diabetes, and we heard a little bit about breast cancer and the improvements in breast cancer over the last 5 years. There haven't been the same improvements in lung cancer. Patients with lung cancer die. The 5-year survival is still around 18%. 20 years ago, it was 13%. So in those 20 years, we've made hardly any improvements. But the truth is that clinicians like myself, pharmacists, occupational therapists, they document in exquisite detail every aspect of the patient journey. But this is where it stays. It doesn't get used to improve health outcomes, and it doesn't get used to improve the healthcare service. And the reason for that is we just didn't have the technology to abstract those clinical features. All we had were teams of individuals who were tasked with reviewing a couple of those and abstracting some small amounts of information. We've heard a little bit about the digitization of the health record, and over the last 5-10 years, this is what we've been promised. We've been promised that by digitizing making this record electronic, that we'd get these kind of real-world insights, that we'd get these real-time data analysis, these predictive models. We were all promised that clinicians would be out of work and that everyone would be healthier. But unfortunately, this is the reality. All we've done is taken that same unstructured text and uploaded it onto a computer screen. And if you can't turn this into meaningful and usable data, then all the insights remain trapped and you can't change lives. And so that's what we do at Pentavere. This is where everything is changing. So we take that unstructured text, we feed it through our engine, and we draw out the clinical insights, the clinical features that allow you to answer your questions. We can take in any unstructured text or structured text, so this can be clinical notes, lab reports, pathology reports, radiology reports. That's the input. And the output is high quality research and regulatory grade data that you, clinicians, researchers, pharmaceutical companies, can use for policy decisions, clinical decisions. We work closely with our partners. We don't boil the ocean, so we define all these clinical variables up front, and then we deploy our technology and abstract them. And this can be as a one-time shop, it can be as in batched over a number of months, or it can be as a continual data feed. This is what's really challenging. This is the really hard part. And this is what stopped healthcare really taking advantage of all these kind of advances in AI, all these predictive models, because we don't have the large data sets or large labeled data. And this is our core capability, taking this unstructured data and turning it into meaningful, usable, real-world data. And once you have it in this format, everything else becomes relatively easy. You can start to drill down into this data. You can ask questions of it. You can identify at-risk populations. You can look for new treatment paradigms. You can use this data to feed your predictive models and start to try and put clinicians out of work. But what we know at Pentavere is that it all starts with good data. I started off by talking a little bit about my journey and becoming a clinician and how I made the decision to leave. But in many ways, I'm no different to all other clinicians. We all have big ideas about how we're going to change healthcare and make the world a better place. What I realized during my clinical practice was that I wasn't going to be able to affect change in the healthcare system from within the healthcare system. But by working at Pentavere and using the technology we have, I'm able to be involved in projects right now across Canada that are changing the healthcare system and therefore are changing patients' lives. So if this sounds interesting to you, if this is the sort of thing that interests you, please ask some questions or come and see me afterwards. Thank you.
So my father had lung cancer, and one of Christopher's clients, I guess Natasha Lael, is a really good friend of our family, and she treated my dad. And I think his fall was triple the size.
Right.
He was only with her for 9 months. So I completely think that this is an incredible innovation that you're doing. I will have one question before I throw it to the audience. So you're a private company?
Yes.
Are you raising?
We're a company. We're not currently raising. No. We commercially launched in 2016. We've got a kind of a supportive board of high net worth individuals, and now we generate revenue. So we're making money. We're one of the few technology companies.
And are you hiring?
Making money. We are hiring. We're growing rapidly.
What roles are you hiring for?
So typically on the tech side, so engineers, NLP engineer. Our software is AI and NLP, so NLP engineers. But also on the project management and the clinical side, I'm building out my team to manage all these projects that we're doing across Canada and in Europe now as well.
Amazing, and we had someone in the audience, I think, looking for a job in oncology marketing. So I think this is almost a perfect fit. Any questions from the audience? I think we're going to take two.
Hi, actually, just two questions. How do you manage data privacy and data jurisdiction issues?
Right, that's a really great question. I didn't touch on it too much because we only have 5 minutes. So the data stays within the institution. So the patient level data never leaves the institution. Our technology is architected in such a way that we can deploy within the institution, and that remains the property of the institution. So we work within all the frameworks, whether it's PHIPAA or different frameworks around the world, to ensure that the patient notes and privacy is protected above all else, because we know how important that is. Then within the framework of that, within the constraints of that, we then have contracts that allow certain elements of usually aggregated data to leave to, say, our pharma clients.
And one last question. One last question.
Yep.
So we know that text to insight translation through AI is not always perfect. So could you speak a bit about your quality assurance and quality control processes?
Yeah, right, absolutely. So I think I briefly mentioned it. I meant to mention it if I didn't. So we work very closely with our partners to define up front what those clinical features and clinical variables are. That process we call building out the gold standard. So we'll build our gold standard, the rules that govern that data extraction process. We then tune to those rules. So we'll do a first cut of data and see kind of what it looks like. We base our results on precision and recall, and if they don't meet sufficient targets, then we'll adjust the rules to ensure that we're meeting those targets. And it's an iterative process. Over the past 2 years, we've become pretty good at it. So actually, that iterative process that used to take a while is now much more focused, and we're able to achieve the kind of the 95, 98% F1 scores that we require for the research and regulatory grade data that we're kind of holding ourselves accountable for.
Well, I love what you're doing. Change the world. I think it's amazing.
Thanks so
really,
much.
really great.
Thank you.
Yep. So.